respectful of our time and do what we need to do. Okay, yesterday we covered, okay. Now guys, we just got to be respectful of everybody in here. Don't have your private conversations when we're all trying to listen. Because everybody in here's, somebody's paying for this education, okay? So we just want to make sure everybody has a chance to hear what's going on. And yesterday there was a little more chatter in here than I really liked. So let's try to be respectful of each other. And y'all can do very well on this test tomorrow. I know you can. Folks have in the past. All right? So we want to make sure everybody in here has that equal opportunity and can hear what everybody's having to say. So I want you to listen to what people say whenever they're presenting this, because I can't go back over every little thing. We don't have time for that. So I just want you to have the opportunity to hear. And then, of course, I don't know if y'all are going to take a picture of these posters or whatever, but, you know, I'll have to take them down before the day's out. Okay? So if you need a picture or whatever, I hope you get them. Okay? All right. So we've already talked about HIV and AIDS. We've talked about Guillain-Barré, myasthenia gravis, and systemic lupus erythematosus. Now today we're going to finish up the topics, and one of the big topics, and if you want to spend some time on one of them, rheumatoid arthritis is one you might want to spend some time on. Okay? It's a big topic. And I want y'all to keep in mind too, there are, I don't know how many questions on this test, 23, something like that.
Yes, ma'am.
As it relates to immunity, the others are metabolism. But you will see questions on your final, comprehensive final that relates to all these topics. So just because you don't see something on this test tomorrow, doesn't mean that you don't have to carry this information forward for your final. And that's when, next week?
Yes, ma'am.
Okay. So I'm just telling you, you know, you need to make sure that you remember all these things, not just past tomorrow. I mean, just for tomorrow. Remember it ever, okay? All right. So who's going to talk to us about the rheumatoid arthritis? Hopefully somebody. Okay.
Alright. Signs and symptoms of rheumatoid arthritis: pain, weakness in movement, joint swelling, stiffness, weakness, fatigue, weight loss, subcutaneous, and rheumatoid nodules. Some nursing interventions for it is keep moving to prevent contractures, active and passive range of motion to give pain meds, place heat on the joints to help with mobility, to rest and exercise, use of physical therapy and occupational therapy, use some assistive devices such as handrails, Velcro fasteners, hand grips for utensils, long handle reachers, and raised toilet seats. And you need to use large joints instead of small bones. Do not bend at your waist and try to conserve your energy. Some labs for it is the ESR, C-reactive protein, the rheumatoid factor, and the ANA. And the C-reactive protein is more specific to inflammation. To diagnosis, you do a arthrocentesis, and that's where they insert a large needle into the joint and aspirate a sample of the synovial fluid. And after the procedure, you use ice and you rest the joint for 24 hours, and you notify healthcare provider of bleeding and synovial fluid leakage. Some medicines that you use to treat it is some methotrexate, some opiates for short-term periods, amitriptyline, and
Etanercept?
Yeah. And when using that, you need to rotate your sites, and it blocks the TNF alpha, and the amitriptyline, it aids in sleep, and the methotrexate is an immunosuppressive drug.
Okay. All right. Well, let's talk about rheumatoid for a little bit. All right, first of all, who in here is taking care of a patient with rheumatoid arthritis? Just a few of you? That's real surprising. Okay. All right. Well, I've taken care of a lot of folks that has had rheumatoid arthritis, and they, being an autoimmune type disorder that has to do with that synovial fluid that she mentioned earlier, in the joints, that's what's causing the issue there, the body's fighting that. And so what happens with these folks, though, they have those flare-ups or exacerbations just like some of these other autoimmune disorders have, like lupus, for instance, okay? So you need to think that there is going to be different ways to manage rheumatoid arthritis depending on whether or not it's a flare-up or whether it's just a chronic day, okay? So in talking about that, what would you see that might be different in a person who has a flare-up with rheumatoid arthritis, knowing that it has to do with those joints and that synovial fluid?
Like a hot, swollen joint?
That is correct. That's what I was looking for. The thing about it, and why is that important at that moment? What you going to watch for?
Infection.
Infection. Absolutely. So see, y'all got this. Once it's answered anyway. The thing about it is that's what you think about. When you have a person who has a flare-up, that means an exacerbation. That's something out of the norm, okay? And that can put a person at risk for having an infection if they have a really hot, swollen red joint, okay? Now, think about during that time, if they're having a flare-up, what kind of exercises should they do? Like she pointed out, you know, they need to stay mobile, right? People have to stay moving because if you don't move, you can't move, right? So we need to keep them moving on a day-to-day basis anyway. And what kind of exercises would they do on a normal day?
Like low impact, like
Low
swimming,
impact.
biking, walking.
Okay. All right. What kind of range of motion? Active. They're doing it themselves, right? Okay. But when they have this flare-up or this exacerbation, what's going to happen? Pass. You see what I'm talking about? Hello there. All right. That's not me talking. You know what I'm saying. I don't know what that was. But what I'm telling y'all is like I tried to lead you in the path yesterday about starting to think about things a little differently at this level. Because, you know, if you know what's normal, you know what's not normal. Okay? And if you know that these folks do these things when they're in their normal situation, then what are they going to do when they're not in their normal situation? If you think like that, then you can apply a lot of knowledge to things. And I heard y'all talking about your metabolism. And you're talking about getting confused between the two, the hypos and the hypers. All right? If you know one of them, you should know the other. If you know what low is, low, then it's the opposite for the hyper. I would think, in most situations, right? If you have somebody who has, and I'm just using this as an example because y'all got this topic on your test. If you've got somebody who has, say, hypothyroidism, all right, do they have diarrhea or constipation?
Constipation.
If they have hyperthyroidism, what might they have?
Diarrhea.
Or diarrhea. If they have hypothyroidism, what's their pulse rate?
Low.
If they have hyper, what's the pulse rate?
High.
Okay. Low is slow, right? Okay. I'm just trying to give you ways to think of things a little differently. It may not help you, but it might. But same goes for these disorders sometimes here, like with flare-ups. That's kind of the same concept as what I'm saying. is that this is the way it is here, but this is the way it is here. Y'all following me? Okay. All right, so if you've got somebody who has this rheumatoid arthritis and they're having a flare-up and you're helping them exercise, because that's passive exercises, because they're not able, why aren't they able to do those exercises like they normally would?
But their joints are swollen and pain.
They're swollen and they hurt, right? Okay, and they may have an infection. You know, there may be something going on there. So, we understand about how that works. All right, you know people that are in the bed too long can get contractures, right? So what do we do for people like rheumatoid arthritis folks who get contractures or start looking like they're gonna get contractures? What do we do for that? Yeah, we're gonna do all of that. Now, do you put pillows under their knees? And how do they lay on the bed? Huh? Pretty flat?
Yeah.
Okay. All right. You want to keep them, you know, straight, right? So they don't contract. All right? Now, I've taken care of a lot of old folks in my lifetime that had contractures. Okay? I want to tell y'all a story that it stuck with me my whole career. I was taking care of a lady that died at home. And before she died, she had some interesting things happen to her. And one is she swallowed her false teeth. Okay? I'm just telling y'all this because I've seen this twice in my career, and it's just the kind of thing that sticks with you. You know what I mean? You just kind of remember. Well, she had this lump in her throat when I went to see her. And she was still eating and drinking. You know what I'm saying? And I couldn't figure this thing out. So, of course, I reported it, you know. It's got a big lump, and I don't know what this is. Well, when I came back, she had coughed and coughed them up. Okay? All right. That was just interesting to me. I'm just telling y'all this stuff. The other thing, and I saw that in the hospital too. And what was interesting about that is since I had seen it with that lady, and then I seen this guy in the hospital with this lump, I thought, he done swallowed his teeth. And sure did. Sure did. Okay, that's just information, sideline. But you may come across that one day, you never know. All right, the other thing about this lady that was interesting though, when she passed away, I was privileged and honored to go out to the house where she was. And the lady had been contracted for years with her arms up like this. And when she died, took her last breath, I just laid those arms right on there. Okay? And that was the most amazing thing to me. So when I talk about things like this, it reminds me of the reason that we want to make sure they don't get these contractures. You know, because once they get there, you don't get them down until they pass away. Okay? So, anyway, I just like to share a little bit of my experience along the way, you know, because you live and learn, right? And y'all will too. You'll have a lot of experiences that you won't forget. So, you know, you're going to prevent a lot of these flexion contractions is by keeping them flat, you know. You know, they may even lay on their belly and hang their feet off or something. They still need to move even though it's painful, you know, and that's what's unfortunate, but they do. They have to keep moving. All right, so we talked about the exacerbations and such. Now, you mentioned up there about things at home that, and at the hospital even too, that might help them to be more independent, okay? To help them with their activities of daily living. Things that they do on a day-to-day basis that they may be starting to have some problems doing for themselves. So, what was one of the things that they mentioned about what would help these folks to stay independent at home? She just talked about it.
Like bigger utensils, assistive devices.
Yeah, that's right, assistive devices such as. She mentioned the bigger utensils, you know, sometimes they need those bigger utensils to be able to eat with, okay? What else?
Velcro instead of buttons.
Velcro instead of buttons. What else she say? Raised toilet seats. I'm checking to see if y'all paying her any attention. What else? That's right. You know what? Here's another story. It ain't very long. My grandson, he wanted one of them grabbers. You know how you do them little, you squeeze them things, they grab stuff, you know what I'm saying? And I got me a new washing machine a year or so ago, and I couldn't reach my clothes. So I used the grabber. So they work. So, you know, I'm just saying. Some of you short folks might need one for your washing machine. I don't know.
Yes, we do.
But I just got tired of my head getting down there and trying to touch back on the floor, you know. That was a little different. Okay, another thing on my list here that she didn't mention there was maybe having a toothbrush that had a built-up handle, you know, just like the eating utensils would be. And of course, in the hospital, you know, sometimes we'll have y'all know those little what they call trapeze bars or something, that sometimes they can pull themselves and move themselves a little bit with those. Okay, so that's what we're talking about there. There's a lot of things that folks that have issues with those joints need. And that's just to name some of them. All right, now, we haven't talked much about the labs, and this is really a good time to talk about the labs with the rheumatoid arthritis, because a lot of these labs are checking for inflammation, and she mentioned some of those. And so let's talk about them. You know, the rheumatoid factor. You know, like some of us were talking about yesterday on that, it's got the RH factor. I think that might be a typo. It should be in like an RF, you know. So we'll go with that. We're going to say it's the rheumatoid factor. And you know what that does is that shows that somebody has got antibodies, you know, that have built up in their blood that would indicate, you know, that they have rheumatoid arthritis. There are other tests like the ESR, the erythrocyte sedimentation rate. Do y'all, in your book, I want to just call your attention to this. I want to say this, but I want to make sure I explain this a little bit. If you've got antibodies in the blood, and you're measuring for antibodies, then that means that your body has built up these antibodies against something, okay? All right. Like, for instance, if you have myasthenia gravis, and myasthenia gravis, y'all remember what is affected? What is that that's affected in the body? Okay, but what's the name of that chemical? Acetylcholine. That's right. The acetylcholine receptors is what's being attacked, okay, in the myasthenia gravis. So if they did a blood test to check for antibodies, for the acetylcholine antibodies, if a person has myasthenia gravis, then they would probably see antibodies for the acetylcholine, right? That the body has attacked that, all right? And if they don't have any antibodies, then chances are they don't have myasthenia gravis, right? Okay, so that's the purpose of that. I'm trying to make it so you can understand that. So, in the erythrocyte sedimentation, there are lab values that they look at to kind of indicate how much inflammation is there. In your book, I don't know if this is still correct, but I wrote this down, and y'all might want to check on it, okay? There's a chart, and it's in chapter 18, and it is 18-8, okay? Y'all look at that and see if that's where these lab values are.
It's in the old book.
Huh?
Like that. It's in the old book like that. In the 8th edition.
Yeah, that's usually what I'm using. Okay, y'all got the 8th edition, most of you, or not? No?
It's 18.8, but it's usually the same in the 9th edition too.
Okay, well, I'm just telling y'all, there's a chart in there. You do this erythrocyte, SID rate, normal values, and I have on my notes, and I hope it hasn't changed, but I had that usually males will have up to like 15 millimeters per hour, and the females will be 20 millimeters per hour. So if you see a SID rate that's over that, then you would think that person has more inflammation than they should have. Does that, y'all understand what I'm saying? Mm-hmm. Okay. All right, now, the SID rate, y'all know how that works? Y'all know how that lab works? They put a drop of blood in this solution, they watch how long it takes it to settle to the bottom. It's called the SID rate. Duh. Okay. So anyway, you know what? They still do that, but the C-reactive protein that she mentioned earlier, that C-reactive protein, that's a more sensitive test and a quicker test. Okay? So a lot of times they'll do the C-reactive protein to see, if the body is kind of showing that much inflammation. All right, and we have what we call the ANA, or the anti-nuclear antibody test. Well, guess what? That's checking for antibodies, right? And we just talked about when you have those positive antibodies, right? That means somehow or another you've had some kind of inflammation going on, and your body has built up some antibodies. So, I just wanted to go over some of those because that's on your objectives, and they did a good job about talking about them back there. But I do want you to go back and just review those so you'll have it in your mind what that means. Because there are some of these tests, like the ESR, that does have a value that you need to know. Okay? All right, now we're going to talk a little bit about medications as it relates to rheumatoid arthritis. All right. The one that you all mentioned up there, y'all realize that there are a lot of meds that they're going to give for rheumatoid arthritis. All right, they may give what we call those COX-2 inhibitors, okay, like the Celebrex, okay. They give what? Do they give NSAIDs? Okay. They give methotrexate. They give, what was the one you mentioned, the what? Etanercept? Okay, let's talk about etanercept for just a minute. Etanercept is, I think what's the name, Enbrel maybe? For that, that's the one I used to know it by. I'm trying to learn these generic names. But this one is given subcutaneous. Etanercept is given subcutaneous. Did you mention that back there on your board? I believe you did, right?
Yeah, about rotating the site.
Yes, about rotating the site. And that's what I was trying to get to there, is that as nurses, it's our responsibility to make sure these folks know how to give that injection if they're in the hospital when they're prescribed that. They can't go home with this medication and not understand about how to give a sub-Q injection and how to rotate the sites and how to be safe with handling their sharps. So just keep that in mind as you go through your nursing, whether they're getting on insulin or whether they're giving themselves this medication, etanercept. They have to, know how to give it to themselves, okay? And this is just one that happens to be common for your rheumatoid arthritis. Prednisone. You think they might give that? Okay. And there's something that we need to remember about steroids. If people take steroids for a long period of time, what can that cause?
Osteoporosis.
Osteoporosis. And what do we do for that?
Give them calcium.
Calcium and what?
Vitamin D.
Vitamin D to help absorb that calcium, right? Okay. So as long as y'all start thinking about, it doesn't hinge on just one thing. You have to think about what that might cause, what these drugs may cause. Now, all right, let's think about this one. And I'm gonna tell you this name. It was cytoxin in my day, okay? But it's cyclophosphamide. Cyclophosphamide. This is a chemo-type drug like methotrexate, okay? But I want you to understand that they're giving different types of drugs for different conditions, and even with rheumatoid, you've got different types of classifications of drugs that people get. Well, with this one in particular, the cyclophosphamide, and it being a chemotherapy type drug, what are we going to watch for with that one?
Infection.
Infection. Absolutely. And y'all know when I talked to you yesterday about thinking about that? When you think about any of these cancer drugs or any of these chemo drugs, they may not be given for cancer, right? But they're going to have the same kind of side effects, right? Okay. And why, let's take this a step further, is why are these folks going to be at a risk for an infection when they take this cyclophosphamide?
Because it weakens their immune system.
That is correct. And when it causes them to be immunocompromised, physiologically, what is it doing? Press that. What is it doing physiologically? What's happening that's going to cause them to be more susceptible to an infection?
Killing the white blood cells.
That's correct. It's reducing those white blood cells. It fights infection. Y'all know this. You know what I'm saying? But you got to think more like that as you move forward. Okay? I'm just trying to help y'all in level 4 so that you can start thinking like that. Okay? All right, so we've talked about most of the types of medications that they are going to use for rheumatoid arthritis. And the only thing I didn't mention was like for the NSAIDs. All right, so what do we watch for when people take NSAIDs?
Gastric upset.
Okay, gastric issues, what might happen?
Bleeding,
Yeah,
ulcers.
bleeding. Yeah. So see, if y'all kind of know a little bit about these drugs and their classifications and things that you watch for, then you can figure things out. All right? Because a lot of times people end up with, like for instance, a GI bleed, nobody thinks about, something they're taking for their arthritis. All right? So as nurses though, that's why y'all learn this stuff, is so that whenever you see somebody that's having a problem, well, what are they taking? What might that cause? And we're not going to know everything about everything. That's why we have drug lists, right? We can't know all of them. But you can know some of these things that are priorities that you understand why it happens. Okay, like I say, keep these folks moving. I think that's good. I hope it is, all right? But I want to spend a little time on that, because that's a pretty, and one thing I would like for you to do is, I think you need to take and look in your book at, they've got a hand written, drawn up there, you know, and how they have these little nodules, and how their fingers become deformed because of the lack of that synovial fluid and all in there, okay? So they have all these deformities, all right? There's several hands in your book. It's interesting to see. Now, who has scleroderma? Who's teaching? Who is, y'all doing that? Okay, on the scleroderma, there is a picture of the fingers for someone who has scleroderma. And it looks like little sausages, okay? But the ones for the rheumatoid, you know, they're very crippled, and, you know. That's why they need all those assistive devices, okay? All right, I just want to make mention because the hand was up there and I forgot to mention that, okay? All right, let's talk about gout. Who's got gout? That's another good one. Stand up for us and talk. It carries better up this way. Come on, you tall, stand.
Gout is a form of arthritis characterized by severe pain, redness, and tenderness of joints. The causes are excess of uric acid in the blood, also known as hyperuricemia. The assessment you're going to do is you're going to get some history, age, gender, any medications they're on. For an acute attack of gout, you're going to assess and document joint inflammation and pain. The chronic gout, you're going to check for the presence of tophi, which are skin deposits of urate crystals on the outer ear, arms, and fingers near the joints. You're going to check for infected skin areas and see if they've had any kidney stones or changes in urine output. Okay. For diagnosis, you're going to check the uric acid levels, kidney function, and do a synovial fluid aspiration. Interventions, colchicine, colchicine, yeah, that's a hard one. NSAIDs, allopurinol, probenecid, and you're going to teach them to avoid aspirin because it may interfere with the medications that they're taking. For nutrition, you're going to teach them to stay in a low purine diet because purine it breaks down into that uric acid. So you're going to teach them to avoid organ meats, red meats, shellfish, and oily fish with bones like sardines. Other restrictions include diuretics, excessive physical and emotional stress. Those can exacerbate the disease. And you're going to teach them to drink plenty of fluids, especially water, milk, and citrus juices.
Okay, very good. All right, let me talk about gout for a minute. All right. As she said, it is oversecretion of uric acid, okay? And there are things that can aggravate that. And the uric acid, like she said, comes from those purines, you know, that's made in the body. And so that's why you want to not eat them, all right? So that you don't have more uric acid. I told y'all about the YouTube, you know, that I saw on the gout. And if you've not seen gout before, which I've seen it many times, you might, you know, just want to watch a YouTube video on some of this stuff if you don't understand it. You know, sometimes that just helps you to see things the way it does for me. We have the luxury of all that time to do it here, but we don't. We've got to learn all this stuff so y'all can pass your test tomorrow, right? But anyway, y'all know what a big red toe might look like, though, okay? And it is very painful. You know what I'm saying? That is a very painful, place to be, okay? So what you need to do is you do need to understand what low purine diet is. You know, these organ meats, shellfish, what all did you say back there? Like liver,
Right.
stuff
Oily fish, like sardines.
Okay, all right. So just kind of understand that. All right, and you know hyperuricemia is what's gonna happen. If they do a blood test, they're gonna see a lot of uric acid in the blood, right? Okay, and, normal uric acid levels, I'm just gonna throw these out at you, is what I have on my list, is 2.4 to 6.0 milligrams per deciliter for a female, and it's a little higher for a male, 3.4 to 7.0 for a male. When it gets that high, that means that the kidneys are having trouble getting rid of it, okay? And one thing that you all must remember is that you do not ever limit fluids on these folks. They've got to have those fluids so that it can flush these uric acids out of the body. All right? Now, she mentioned the tophi, which is little white places of the uric acid that will accumulate like on fingers and ears and places, okay? That's a buildup of that uric acid. Shows up as tophi. All right. The other thing that we see is those kidney stones. And so, if this uric acid is high and they're not drinking enough fluids and flushing that uric acid on through, then that means that they can build up a stone in the kidney. And it would be a uric acid type crystal that makes that stone. All right. I've had calcium stones. Anybody in here have a kidney stone? You have? What was yours? Do you know?
From Diet Coke, that's all he told me.
Was it wasn't calcium then, huh? Okay. Anybody else? Well, you either have that or a baby and you know what it's about. Okay.
I don't know, I heard that was worse.
The kidney stone?
Yeah.
It is really.
Especially when you see a 300-pound man laying on the floor balled up like a baby.
I know, but you know, I'm not gonna say what I'm gonna say, but. You know what I'm saying? I'm not gonna say it. But my son had stones, y'all, and that's the reason I'm saying that I can tell y'all the difference here, okay? Is my son had, kidney stones, he had gout. And he had kidney stones several times as a result of it. So I know about this. I had calcium stones because I was put on a calcium supplement with vitamin D to prevent osteoporosis. So do y'all understand what I'm saying there?
Yeah.
You
Yeah,
see
too much.
the difference? Okay. All right. I had a 10 millimeter stone, which is a huge stone. Huge. Okay?
About the size of a quarter, huh?
No, not that.
Not quite that big?
it was pretty good size.
The width of your finger.
But I'm telling
Okay.
you, it was long and slender
So a
kind
dime.
of, and
Size of a dime.
it broke. Is the way I was able to pass that stone. It broke at the mouth of the bladder. Because if it hadn't, I was going to end up with lithotripsy. And y'all know what that is, right? Where they bust up the stone. All right. Well, anyway, having that stone was real aggravating and inconvenient. You know what I mean? It really was. And it's nudged on you all the time kind of thing, you know? So I still remember. But nonetheless, I've had several stones, but that was the big one. But it was calcium related. And, you know, if I fall out here and break a bone, it's just going to have to happen. Because that calcium I can't take. You know what I'm saying? So, the other thing is my son, though, on the opposite side of that, has had several stones that were uric acid type stones. The difference between those two stones is that the calcium stone is slick. that calcium is slippery. Slips. He had barbs, and he had a little old tiny thing like a mustard seed with barbs.
Ugh.
Cause it's crystal.
Huh? Yeah,
Cause it's crystal.
because it's crystals. And when that was coming down his ureter, it was cutting it. With them barbs, cutting it as it come down. Where mine slid down hurting, but I mean, it wasn't like it was jabbing in, but I had blood in the urine, even with that, because it was stretching, it was aggravating, okay? But his was really cutting. And so, that little old tiny thing, yeah, he was pulling the carpet up. Yeah. So, I'm just telling y'all, that's the difference in these stones. I just want to give you a free lesson on that. I don't get to teach excretion, but anyway. I just know from personal experience, might help you along the way. But you do not limit fluids. Y'all need to know that for sure. You don't ever limit the fluids on these folks. And another thing that I'll talk to you about is what kind of precipitates these attacks and what can aggravate them. And you mentioned some back there, right? What'd you say?
Stress,
Stress. Stress will kill you anyway, it don't matter.
diuretics.
Diuretics. Why? Why do you want to prevent?
Well, that's removing the fluid that they need.
Okay, so if you're dehydrating them more, that means less fluids to flush out those uric acids, right? Makes perfect sense. The other thing I want to tell you about, though, that will dehydrate them is alcohol. Alcohol will dehydrate. And a lot of times we see people that have, I asked my son, how much you been drinking, son? But anyway, he didn't ask that. But that will dehydrate people. The alcohol, especially, I guess the hard liquors,
It's a diuretic, alcohol's a diuretic.
Yeah.
It's just dehydrated.
Yeah, exactly. And so they need to stay clear of that, okay? Limit their alcohol stuff, you know what I mean? All right, so diuretics, and also they talk about severe starving, they don't need to. And he was a dieter. I think that was his biggest problem. He was trying to lose too much weight, not eat. Okay? So that can be a problem too. All right. On your PowerPoint, it says that hyperuricemia is greater than 7 milligrams per deciliter, just as a side note. All right, let me see what else I got on here I might want to say. All right, y'all know about the foods. We talked about that. But, they do have meds, like they mentioned, that would treat the gout. And allopurinol is one of them. And they use that a lot in patients who have issues with their kidneys. That one works better for them. And, people who have kidney stones and stuff like that. They also give them colchicine. You're right. Let's see what else. And the probenecid, this is the other one I want to talk to you about for a second, just for information, because you need, just to be aware. She mentioned about the aspirin, and people want to know, why can't they take aspirin, or why should they stay clear of that when they have gout? And the reason for that is if they're taking the probenecid, like for a chronic thing for gout, then that will kind of deactivate. The aspirin will kind of deactivate that probenecid. It won't do its job. Let's see. Yeah, I think that's probably good enough. You mentioned something though about, would you say milk? I think the ASH diet, if I'm remembering correctly, was something that was suggested in milk. Did you say milk?
Fluids include water, milk, and citrus juices.
Citrus juices, okay. And, like I say, the milk, I always wondered why they could have milk and having a stone, but y'all know now, right?
Yep.
Because it's uric acid.
Not the same kind
Not the
of stone.
stone.
There you go. All right. Okay, I think we're good. Now, we'll take a break. Let's see. Sorry. But see, Miss Lyons took too much of my time. Take